Assalamu alaikum. Dear student, I am Dr. Anisa Sadiq, Senior Registrar Gynae. Today, a lecture will be on polycystic ovary syndrome. And the learning objective of this lecture will be that at the end of the lecture, you people should be able to know the epidemiology of polycystic ovary syndrome, the effect of polycystic ovary syndrome, and how you diagnose polycystic ovary syndrome and how you people will manage it. Polycystic ovary syndrome, it is also called Steen-Leventhan syndrome because it was first diagnosed and described by the Steen-Leventhan. So its second name is Steen-Leventhan syndrome. Now, what is the etiology of polycystic ovary syndrome? The exact etiology of the polycystic ovary syndrome is not clear, but multiple factors are involved in its etiology. Environmental factor, such as genetic factor and lifestyle factor, these are involved in its etiology. And mostly said that almost it is genetic in origin. And there is about and the prevalence of polycystic ovary syndrome. Its prevalence. The prevalence of polycystic ovary syndrome on ultrasound. When we are performing ultrasound and we diagnose polycystic ovary syndrome, its prevalence on ultrasound basis is 25%. And it affects around 5 to 10% of women of the reproductive age. It is previous it was previously 5 to 10%, but nowadays we are seeing every third lady is suffering from polycystic ovary syndrome. Now the incidence and prevalence is increased, maybe due to the change in lifestyle, maybe increased change in the environmental factor. Because every time when we are performing OPD and checking patient, every third woman is suffering from polycystic ovary syndrome. Now, what are the clinical features of the polycystic ovary syndrome? How the patient will present? Mostly patient presenting with the menstrual irregularities. And menstrual irregularity, mostly female presenting with oligomenorrhea. Oligomenorrhea or amenorrhea. Oligomenorrhea, and every patient is presenting with oligomenorrhea. In oligomenorrhea, there is the periods are absent for 3 to 4 months, in some patient for 6 months, and in some patient almost 1 year amenorrhea. With 1 year amenorrhea, the patient are female are presenting. And this amenorrhea or oligomenorrhea is usually due to ovulation, because the ovulation doesn't occur in the patient suffering from polycystic ovary syndrome. So this ovulation lead to oligomenorrhea and amenorrhea. And in some patients, the cycle are regular, but there is sign of androgen excess, because the androgen are increased in amount in patient with PCO. So they are presenting with androgenic clinical feature in the form of hirsutism and acne. In polycystic ovary syndrome, androgen is basically a male hormone, but in the polycystic ovary syndrome, this male hormone is very much increased in amount in patient with polycystic ovary syndrome. Some patients are presenting with obese. Some patients are obese, and if the female are married, then almost 75% of the women are suffering from subfertility, mean infertility. And this infertility and PCOS is due to an evolutive cycle because the ovum are not forming, the follicle is not forming, and the ovum is not released. So the cycles are involuntary and the patient are suffering from subfertility. Some patient presenting with acanthosis nigricans, and this acanthosis nigricans is basically the area of pigmentation and velvety appearance, mostly in the armpit. And some patients have a feature of polycystic ovary syndrome, but they are asymptomatic. Now, this is a picture which is showing a patient with polycystic ovary syndrome. They have increased hair growth on the chin. Mostly some patients are presenting with male type hair on their face. In this hair growth is also is staging, but the stages are not much important at this level. And this picture is showing acanthosis nigricans. This is armpit, and this is area of dark pigmentation and velvety appearance in the axilla. This is acanthosis nigricans, and this is hirsutism. This is second picture, which is showing a patient suffering from polycystic ovary syndrome, but this picture is not much clear. Uh, Picture is not much clear, but here is some feature like acne, this acne, weight changes, mood changes, decreased libido, ovarian cyst, abdominal pain, and excessive hair growth. And this is mood changes. This picture is showing the symptom of polycystic ovary syndrome. Now, how you people will diagnose the patient with polycystic ovary syndrome? In diagnosis, the patient must have two out of the three features which are listed below. For diagnosis, the patient must be having two features and the following three features. Patient will be presenting either with amenorrhea or oligomenorrhea. There should be either clinical or biochemical evidence of hyperandrogenism. Either the patient there should be manifestation of the hyperandrogenism clinically or biochemically. Mean in clinical, the patient will presenting with the male pattern hair, hirsutism, or with acne. And biochemically, there will be increased androgen hormone level and laboratory investigation. And third criteria is polycystic ovaries and ultrasound. When we are performing ultrasound, the ovaries should be having an appearance of polycystic ovaries. In these three features, the patient must be having two for the diagnosis to fulfill the criteria of the polycystic ovary syndrome. And this criteria is called Rotterdam criteria. And this is very important for MCQ's point of view that what is Rotterdam criteria? Not this is Rotterdam criteria. Ultrasound criteria. What is the ultrasound criteria? How we will say that this ovary is having polycystic appearance, or in which ovary will be polycystic? The ultrasound criteria for the diagnosis of a polycystic ovary are there should be 8 or more, or less than 10 subcapsular follicular cysts, small cysts, and they should be less than 10 millimeter in diameter. And there should be increased ovarian stroma. The polycystic appearance at the ultrasound is called string of per side. String of per side. The ovaries is having appearance of like a bird. This is the appearance. This is a normal ovary which is showing the dominant follicle and what this follicle, and this is a ovary which is having polycystic appearance. Polycystic appearance. There are multiple small follicles. This is basically follicle which are not maturing and they are undergoing atresia, and this is giving the appearance of like a string of pearl. String of pearl. So it is called string of pearl side. And this picture is also showing the ovaries. This is a healthy ovary, and its surface is smooth, and this is a polycystic ovary. The small cyst, a small follicle, these are also visible on the surface of the ovary when we are performing ultrasound or when we are performing some surgeries. The polycystic ovary is seen like this. Now, what are the key hormonal abnormalities in polycystic ovary syndrome? What investigation are we performing for polycystic ovary syndrome? The one is ultrasound. In ultrasound, I have told you that the ovary will be having the appearance of polycystic, multiple cysts, and and, and there should be the other thing is hormonal assay. In hormone, we are performing the luteinizing hormone level and the follicle stimulating hormone level and some other investigation. In the polycystic ovary syndrome, there is increased level of the luteinizing hormone. Luteinizing hormone is much more increased in the polycystic ovary. And normally, when the patient is normal, there is no polycystic ovary. The follicle stimulating hormone level is increased and the luteinizing hormone level is decreased. When a patient is suffering from polycystic ovary syndrome, this ratio is reversed. This, this is reversed. The LH level become increased and the follicle stimulating hormone level become decreased. The ratio is reversed, mean increase LH and decrease FSH. When there is increased level of luteinizing hormone, what it will do? The mechanism is like the increased luteinizing hormone level, it acts on the theca and tanda cell. And this theca and tanda cells in the ovary then produces increased amount of androgen. Androgen are increased and due to the this increased production or the influence of luteinizing hormone level. When androgen is increases, it is converted into the peripheral tissue. In the peripheral adipose tissue to the estrogen. And this conversion from androgen to the estrogen occur under the influence of enzyme aromatase. When estrogen is when there is increased amount of estrogen, this estrogen give a negative feedback to the follicle stimulating hormone. So the follicle stimulating hormone level is decreases when there is no follicle stimulating hormone, or the follicle stimulating hormone level is decreased in amount. The follicle in the ovaries not undergoing development. No mature follicle is formed And the follicle which are present inside under the ovary, they undergo atresia, they undergo atretic. So no ovulation occurs. When no ovulation occurs, the ovaries is having the appearance of polycystic, and due to an evolution, the menstrual cycle become anovulatory. Mean patient presenting with the amenorrhea and oligomenorrhea. And this increased estrogen level also further increases the luteinizing hormone level, and the vicious circle is going on and on. And this due to the increased LH level, when FSH level is decreases, the end evolution occur and the ovary is having the appearance of the polycystic ovary. Now, the second thing is insulin resistance, which are seen in the patient with polycystic ovary syndrome. In insulin resistant, in the patient with polycystic ovary syndrome, insulin is present, but it is not working. It is present in increased amount, but it is not metabolizing the glucose. It is resistant to insulin. So the increase in amount of insulin give again a positive feedback to the theca cell, and again the theca cell start producing androgen, and this androgen again is converted in the peripheral adipose tissue to the estrogen, and estrogen is increases. When the estrogen is increases, it give a negative feedback to follicle stimulating hormone, and follicle stimulating hormone is decreases, and it causes stop the development of the mature follicle and evolution. Insulin plus androgen together act on the liver, and in the liver they suppresses the sex hormone binding globulin. This sex hormone binding globulin, which is binding the estrogen and androgen, estrogen and androgen. When this is in decreased amount, when sex hormone binding globulin level are low, the estrogen and androgen will be not bounding to this binding globulin, and they are present in increased amount in the peripheral circulation, and this and will be biologically active. And this free estrogen and estrogen are responsible for the clinical manifestation of the polycystic ovary syndrome. More androgenic and more estrogenic clinical feature, more acne, hirsutism, mood changes. So this is very important, that insulin resistant in the polycystic ovary disease. Now, just a review that which hormone are increased in the patient suffering from polycystic ovary syndrome and which are decreases in patient with polycystic syndrome. Hormone which are increases in patient with polycystic ovary syndrome, but is, as I have already discussed with you, this is the main thing is luteinizing hormone, which are much increased in patient with the polycystic ovary syndrome, and due to this the estrogen level is increased, the androgen level is increased, and in some patients which are suffering from polycystic ovary syndrome, there is hyperprolactinemia. The prolactin level are also increased. And this cholesterol, LDL cholesterol, which is called bad cholesterol, this is also increased in patient with polycystic ovary syndrome. So the patient with polycystic ovary syndrome are almost obese. There is obesity. And the hormone which are decreased in the polycystic ovary syndrome are decreased follicle stimulating hormone. There is decreased progesterone level. Progesterone level is also decreased in patient with the polycystic ovary syndrome. The decreased progesterone level, and there is decreased sex hormone binding globulin level, which is also decreased, due to which the estrogen and androgen are present in increased free form in the circulation. and the good cholesterol, HDL cholesterol, high density cholesterol. This is also decreased in patient with polycystic ovary syndrome. Now, how we will manage the patient suffering from polycystic ovary syndrome? The polycystic ovary syndrome, it is basically a syndrome, not a single disease. So the to management will be point towards the different feature which are present in the polycystic ovary syndrome. One thing is the patient suffering from menstrual irregularity, the patient mostly presenting as I already told you, either with the oligomenorrhea or amenorrhea. So, for cycle regularity, that the patient menstrual cycle become regular, we are prescribing combined oral contraceptive pill. Combined oral contraceptive pill, it decreases the LH level and the follicle. Combined oral contraceptive pill and cyclical or oral progesterone level. These two things decreases the luteinizing hormone level. When the luteinizing hormone level is decreased, the estrogen will be decreases and it will be giving a positive feedback for the production of the follicle stimulating hormone. When follicle stimulating hormone is releasing, the cycle will become follicle stimulating hormone. Follicle stimulating hormone will cause the production of the graphene follicle and ovulation. And when ovulation is occurring, the cycle will become regular. Remember that ovulatory cycle are regular and painful, and non-evolutionary cycle are irregular, just like in polycystic ovary syndrome. And this combined oral contraceptive pill also improve the feature of the androgenic axis. As I have already told you, that due to androgen, there is increased hirsutism and acne. When we are prescribing to patient the combined oral contraceptive pill, it decreases the LH level. So androgenic manifestation are also decreases with the COCP. Second thing is the lifestyle advice. Lifestyle advice mean dietary modification and exercise and weight reduction. And the weight reduction is very important because mostly patients are obese. And the second thing is that due to weight reduction, there is decrease in adipose tissue. When adipose tissue is in decreased amount, the aromatase activity will be decreasing. And so the androgen, which is converted into estrogen, will be not converting and will be converting in decreased amount. So when the estrogen is decreasing, it will increasing the production of the FSH, follicle stimulating hormone. And this follicle stimulating hormone will then lead to ovulatory cycle. The second thing is metformin. Metformin, it is a anti-diabetic drug because I have already told you that there is insulin resistant. Insulin is present, but the glucose is not responding to it. So we are prescribing the metformin. Due to metformin, one thing is that the weight are reduced, and the second thing is the glucose metabolism will start it. Metformin mostly in the form of glucophage, we are prescribing to the patient with polycystic ovary syndrome. Now, we are treating in PCO patient the menstrual irregularity, the obesity, and the one who are suffering from infertility. As I have told you in previous slide, that the patient with polycystic ovary syndrome are mostly suffering from infertility. So the infertility is, as I have told you, that infertility in PCO is due to an evolution. So we are inducing evolution in these patients with clomiphene citrate And the second drug is letrozole. Letrozole is aromatase inhibitor, and the chlorophene citrate, it causes ovulation induction and patient with the infertility. And these drug have its own sides effect, like chlorophene citrate will cause ovarian cyst formation, hyperstimulation of the ovary. Now, other thing is ovarian drilling. Ovarian drilling is basically, as I have told you, that there is ultrasound criteria for the polycystic ovary. When there are multiple cysts or small follicle in the ovary, we are not responding to medication, then we during laparotomy or during laparoscopic surgery, then we are performing ovarian drilling. Ovarian drilling is basically doing small hole, small cut and the cysts which are present in the ovary with cautery or with needle prick. We are doing small cut on the cyst and the ovary. So this is called ovarian drilling. And the second is GnRH analog. GnRH analog is a last resort for all those patients which are not responding to the other medication. Now, how will treat hirsutism and androgenic symptom in patient? There are medical treatment and surgical treatment. In the medical treatment, we are prescribing to the patient the drug which is called a cream. Its name is E-clonidine cream and its trade name is Venica. Very important. It is used for the androgenic symptom. And the second thing is the protein acetate, oral contraceptive pill, as I have told you, and spironolactone. These all are anti-androgenic drug. Anti-androgenic drug. And these anti-androgenic drug causes these anti-androgenic drugs are used for the treatment of hirsutism. And the last treatment is surgical treatment, mostly for the hirsutism, and laser and electrolysis are used. Patients are using laser and electrolysis as surgical treatment for hirsutism. The treatment of the hirsutism is prolonged. In other words, the PCO treatment is prolonged. A patient at least need 6 to 9 month treatment to have improvement in their clinical feature. This is a picture which is showing lifestyle changes to manage polycystic ovary syndrome. Maintain a healthy weight, have regular health advice, keep your stress in check with yoga and meditation, doing exercise, and quit smoking. This lifestyle modification in patients suffering from polycystic ovary syndrome. This is a dietary advice because polycystic ovary patients are almost suffering from obesity. So, to reduce weight loss, vegetable, lemon, and high fiber diet are advised. Now, there are certain syndrome which are associated with polycystic ovary syndrome. One is HAIR syndrome. This is hyperandrogenic insulin resistant syndrome, which is associated with polycystic ovary syndrome. And the second is metabolic syndrome. This is a different syndrome. These are associated with polycystic ovary syndrome. Now, what are the long-term consequences of polycystic ovary syndrome? As I have already told you, that due to increased LH level, there is increased estrogen level. When there is increased estrogen level, there is increased proliferation of the uterine endometrium. When there is increased proliferation of the uterine endometrium, there will be endometrial hyperplasia, and this hyperplasia is later on changed to endometrial carcinoma. So, the patient with polycystic ovary syndrome are at a risk of endometrial hyperplasia and endometrial carcinoma. And as I have told you, that there is insulin resistance. So the patient are at the risk of developing type 2 diabetes mellitus. And also the patient with polycystic ovary syndrome are at the risk of developing cardiovascular disease due to increased obesity, type 2 multiple organ diseases, type 2 diabetes mellitus. So the patient are at the risk of developing cardiovascular diseases. And I have already told you that the married ladies are in 75% of patients are presenting with infertility, which is very depressing. You people can take help from internet website by different images and studied in detail in the Guiding 10 Teacher Book 20th edition. If you people have any query, you people can give feedback. Thank you so much.